Hi there, I'm Professor Drew Richardson from Canberra, Australia, and this is my poster on the increasing incidence of prolonged boarding in mental health presentations in Australasia in 2020. I'd like to thank my co-author and to note that this study was funded by the Australasian College for Emergency Medicine. There are no conflicts of interest to declare. Mental health patients awaiting inpatient admission are disproportionately likely to experience prolonged boarding, which represents both a patient care issue and an equity issue in emergency departments. This study aimed to collect Australasian incidence data in 2020 at a time when the COVID-19 pandemic was having minimal effects except in one jurisdiction, the state of Victoria. It's a binational voluntary survey of all 150 EDs accredited by the Australasian College for Emergency Medicine. Participating EDs reported data for the 7 days from 19th of October 2020. Mental health presentations were defined as those with a clinical need to see a mental health clinician whilst in the ED, and admissions were defined as those to the ward rather than to short stay units. Prolonged boarding, or access block as we call it, was defined as a total ED time of more than 8 hours for an admitted patient. 59 EDs provided full data, comprising 69,657 presentations and 15,889 admissions. 5% of these were mental health presentations. They were admitted at a slightly higher rate than other presentations, and they had a prolonged boarding rate of 47.5%, significantly higher than 28.6% for non-mental health presentations. There was no significant difference between Australia and New Zealand, but New Zealand numbers were small, with only 8 mental health prolonged boarding cases in the 4 answering hospitals. Now, 24 hospitals answered both this survey and an identical 27th of November 2017 survey. Comparing like with like showed that outside Victoria, presentations rose by 3.6%, mental health presentations by 10.3%, admissions by 10.7%, and mental health admissions by 23%. Prolonged boarding rose significantly from 32.3% to 44.4% in mental health presentations, and 25.3% to 28.9% in the others. In Victoria, there was a 26.6% decrease in presentations, but an 8% increase in mental health presentations, with a reduction in prolonged boarding in both groups. It's worth noting that we already know that Victorian emergency departments are, on average, larger than those in the rest of the country. So the difference between Victoria and the rest here is in the change, not in the absolute figures. In terms of prolonged boarding of mental health presentations, Victoria had issues in 2017, and these have certainly not been resolved in 2020. We know there's been significant political attention paid to the issue of the care of mental health patients in Australasia over the past 4 years. This study confirms that there's actually been a worsening of prolonged boarding for mental health presentations in this time. Obviously, our study has limitations. These are hospital-reported summary data. There's no clinical audit possible, and it's only a single week out of what we all know was a very unusual year. In conclusion, the study confirms that prolonged boarding is much more prevalent in mental health presentations than others. It's increased over the last 3 years in Australasia by much more than the increase in mental health presentations. The jurisdiction affected by COVID-19 saw a decrease in ED presentations, admissions and prolonged boarding, but an increase in overall mental health presentations. Thank you, and I'll take any questions.
Good afternoon, everyone. My name is Chelsea Ledford. I'm a 4th-year medical student at Wake Forest School of Medicine in Winston-Salem, North Carolina. This project is a result of the collaborative efforts of Dr. Megan Hunt, Dr. Jason Stapira, and Dr. Brian Heastan from the Department of Emergency Medicine at Wake Forest University. Our project sought to examine the differences in disposition for psychiatric patients and observation protocol in the community versus the academic setting. Emergency departments are chronically overcrowded. Patients with psychiatric complaints contribute substantially to this, as psychiatric patients often require extended time to evaluate severity and determine disposition. Once a need for admission is determined, the wait for scarce inpatient beds can be substantial. By definition, observation, or OB status, excludes patients who meet inpatient criteria. However, in mid-2019, the AMA CPT committee specifically included psychiatric patients boarding in the ED as eligible for OB status. Accordingly, we established an OBS protocol to include all psychiatric patients who were not immediately discharged after EM evaluation. This included our academic center with separate adult and pediatric EDs and 3 affiliated community EDs. Previously, we demonstrated that this protocol did not result in longer length of stays compared to standard management. Our current study examined differences in OBS and total length of stay times in an academic ED with in-person psych consultation versus community EDs with telepsychiatry. From October 2019 to December 2020, the OBS protocol was implemented in 1 academic center and 3 community EDs. On-site psychiatric consultation and admission were available at the academic ED, while the community EDs used telepsychiatry and transfer of patients requiring admission. Patients were included if they had an order for psych OBS and a length of stay greater than 180 minutes from order to disposition. We collected patient age, sex, disposition, and total and OBS length of stays. Regarding the results, with the exception of proportions of male patients, which did not vary by ED type, the difference between groups in every metric examined, as shown in the table, met criteria for statistical significance. When comparing the academic ED versus the community EDs, the academic ED saw more pediatric patients, had more discharges, shorter total length of stays, and shorter observation length of stays. The difference in LOS persisted with both admitted and discharged patients. The figures demonstrate the difference in the distribution of disposition times, both total and OBS length of stay. The histograms are scaled at 100% of total cohort so that the differences in total number of patients between sites do not obscure the difference in disposition. The difference between the 2 cohorts seems to even out by 48 hours. The substantial tail, which we truncated at 120 hours, is fairly similar in both groups. In conclusion, length of stay was increased and discharge rates were lower in community EDs with a standardized psych ops protocol and telepsych services than at an urban academic site with the same protocol and in-person psych consultation. This may be due to differences inherent in telepsych evaluation, as well as community resources available for safe outpatient management after discharge. Other systems that implement similar psych ops protocols should be prepared for variation between sites. Regarding limitations, we do not have data regarding length of psychiatric inpatient stay after disposition. Even the academic hospital, with access to an on-site inpatient unit, routinely admits patients to facilities throughout the region, making follow-up impossible. We are currently evaluating the specific financial impact of this protocol and look forward to sharing this information at a future session. It was a pleasure to have the opportunity to share our research with you. Please see the bottom of the poster for our contact information and feel free to reach out with any questions. Thank you for your time and attention.
Hello, this is Caleb Washabaugh. I'm a PGY4 psychiatric resident. I'm here to present on my research, which is titled Face Off, Comparing Face-to-Face and Telephone Psychiatric Consultations on Length of Stay and Disposition. Ryan Moore was my assistant and primary author on this research. So why did we do this? So, the ED has been facing increasing psychiatric visits, and it's becoming increasingly problematic for length of stay, as well as financial impact and bed status. There's not enough psychiatric providers nor inpatient beds to offload that. And we wanted to kind of see if different types of psychiatric consultations, in this case telephonic consultations as opposed to in-person face-to-face consultations, made a difference in different outcome measures. So we did this study, a retrospective study of ED patients at a tertiary care ED as well as a community hospital ED in a large rural health system between the time of July 2017 and July 2018. And mostly these were people with psychiatric chief complaints, which we kind of selected or filtered by going through their EMR and selecting those chief complaints. And we differentiated two types of consultations by the telephone versus inpatient face-to-face consultation. And we kind of used we pulled our data from our electronic medical record and the electronic medical record StatIt, which is what our emergency department used to kind of compare these things. So when we compared the two variables, that we used 6 different variables: patient age, patient gender, patient race, type of psychiatric consultation, and triage acuity, as well as whether the consultation was placed after hours or before hours, during business hours. And when we compared those results, we saw a pretty significant difference in ED length of stay, increasing by over 100% with face-to-face consultations compared to telephonic consultations, which we found was a pretty interesting result. Consultation, whether in-person consultation or telephonic consultations, did not correspond with different rates of admission. So, this is a pretty understudied topic, and we wanted to kind of expand on just the data and the understanding of that. And from our study, we saw that that there is a difference between in-person psychiatric consultation and face-to-face consultation. This can be used in a lot of different ways, maybe to help is increasing psychiatric burden and decreasing decreasing ED bed availability. This becomes an increasingly important topic, especially with the COVID-19 pandemic, and how beds become even a higher priority. Things that can be expounded upon, I would say, it would be important to look at telemedicine consultation versus in-person versus telephone consultation and see how those all differ. But that is the main outcome of this, and I appreciate you listening to my presentation. Please email me or reach out to me if you have any questions.
My name is Gloria Essien, and I'm a clinical research assistant with the Department of Emergency Medicine here at the University of Massachusetts Medical School. A lot of words there, but I will be presenting results from an analysis of patient-endorsed suicidality among frequent utilizers within emergency department settings. So study after study has shown that folks who tend to use emergency departments more frequently exhibit poorer physical and mental health. So even among those who present to the ED with chief complaints that aren't necessarily psychiatrics, we still see a high rate of suicidal ideation and behavior among those patients. Kuhn's 2020 research publication, which I cited as reference number 3 on this poster, they found that between 2019 and 2020, EDs across the US saw a 25.5% surge in patients who self-reported suicidal ideation, past suicide attempt, and past or current self-injurious behavior. So all of that being said, the goal of our analyses here are primarily to, 1, compare patient-endorsed suicidality between frequent and non-frequent utilizers in emergency department settings, and 2, secondarily, look to the different relationships between frequent utilizations and different demographic variables, which we'll get into in a little bit. We derived our data from the Clinical Decision Rule Study, the CDR study, which is a longitudinal cohort study that enrolls both psychiatric and non-psychiatric adult age patients across 4 different emergency department sites here in central Massachusetts. Participants who are enrolled in the study are asked a series of questions regarding their mental health and suicide risk, and then they're followed up for a period of 6 months following that index visit. The study is still ongoing, so our sample size of 298 total participants, that includes the total number of participants that were enrolled in the CDR study at the time that we began our analyses for this poster presentation late last year. So frequent ED use is definitely a term that's very prevalent within emergency medicine research. So just to remain consistent with the language that's used in the CDR study, we're referencing these patients as frequent utilizers, or patients who represented to an emergency department 3 or more times following their index visit during that 6-month review period, which we're able to ascertain through chart review. So before we hop into these results here, I just want to highlight that on this graph, we've highlighted our significant results and associations in this pale yellow box with the chi-square and p-values noted right atop them. But all of that being said, of the 298 participants that were enrolled, we identified 41 of those as frequent utilizers and found that participants who endorsed past suicide attempt were more likely to be frequent utilizers than those who did not. So if we're looking at this graph here, which denotes that statistic, all of the patients who responded yes, of all of the patients who responded yes to having a past suicide attempt, 22.5% of those patients were frequent utilizers, while of all who responded no to having had a past suicide attempt, only 10.7% of those were identified as frequent utilizers. So moving forward, we found a marginally significant association of a p-value of 0.06 between frequent utilization and race, where 24.2% of all of the participants who identified as Black or African American were identified as frequent utilizers, while 12.5% of all participants who did not identify as Black or African American were identified as frequent utilizers. So just to wrap this up very nicely, our results found that past suicide attempt was associated with frequent ED utilization subsequently. Our limitation for these results, of course, were our small sample size. Because the study is still ongoing, we only had 298 participants to evaluate. And additionally, if a participant used an emergency department that fell outside of the scope of our 4 site emergency departments here in central Massachusetts, we would not be able to access those medical records to be able to include that data in our results. And lastly, speaking specifically to our marginally significant association between race and frequent utilization, there are a whole lot of confounding variables that can impact or accentuate that association, be it accessibility to preventative care or location. Worcester in particular is noted as a medically underserved urban area. So all of those may contribute to our results as well. But nonetheless, I believe that our results provide good insight into some key psychosocial factors that may predict frequent ED use. And I believe that subsequent research and patient care in general can benefit from evaluating correlations between frequent ED use and different combinations of the baseline variables we use in our analyses here. So that being said, I'll be happy to answer any questions or try to clarify any confusion that you may have in this next portion. Thank you for your time.
Hello, everybody, and thank you for joining me today. I would like to talk to you about the study we performed on the results of drug screens for emergency department patients presenting with psychiatric emergencies in our department. My name is Joshua Masdon, and I'm a third-year resident at Vidant Medical Center and the Brody School of Medicine at ECU in Greenville, North Carolina. Previous research has suggested that patients with substance abuse have a higher likelihood of developing mental illnesses, and patients with mental illnesses are shown to have a nearly twice the likelihood of developing substance abuse. Furthermore, a number of psychiatric illnesses have all been associated with the use of substances such as ethanol, cannabis, cocaine, opiates, and amphetamines. Patients with substance abuse disorders are also reported to express higher levels of depression and anxiety. We work very closely with our psychiatric colleagues at Vidant Medical Center to provide care for patients with psychiatric complaints. Typically, we are requested to collect screening labs, including urinary drug screens on patients. So we sought to investigate whether or not there was an association between the use of specific substances and specific psychiatric illnesses. We looked retrospectively at our patient population at VMC over the year 2019 with a goal of having about 1,000 patient charts to review. We actually resulted thousands of charts, so these were randomly selected in order to have a roughly equal number of patients with the number of psychiatric illnesses listed here on the bottom left. Patients who were incarcerated or who were in police custody at the time of evaluation were subsequently excluded, and a few pediatric patients were likewise identified and excluded. We reviewed their charts for psychiatric history and toxicology results, as well as recorded additional demographic information to assess for any secondary endpoints. We found that 57.8% of our patients with psychiatric illnesses had a history of substance abuse, which accounts for about a 15% increase over those not using. We also noted that patients who have psychiatric illness tend to utilize tobacco products. About 72% of patients with psychiatric illness admit to currently or previously utilizing tobacco. You can see at the bottom the percentage of patients with each psychiatric illness who tested positive for specific drugs of abuse, including salicylates and Tylenol. As you can see, the most popular drugs of abuse included benzodiazepines, cannabis, cocaine, ethanol, and opiates. Our results actually did not demonstrate a significant correlation between specific psychiatric illnesses and specific drugs of abuse. The highest rate of substance abuse was found in patients with schizophrenia and those with schizoaffective disorders. There was no statistically significant relationship between suicide attempts and specific substances that were detected. Similarly, there was no statistically significant difference in suicide attempts between people of different racial backgrounds in our study, specifically African Americans and Caucasians. In our population, African Americans were, however, 60% more likely to use marijuana if they had attempted suicide, and this was statistically significant. When stratified by diagnosis, though, there was no additionally statistically significant difference between African Americans and Caucasians. Our study is likely limited in some ways by selection bias because it is a retrospective study and we had to randomize our patient cohort to get a number of charts that we could utilize for this study. Going forward, I would like to design a prospective study that would allow us to investigate further if there is any relationship that may be detected between specific psychiatric illnesses and specific drugs of abuse. Some specific hypotheses that we may be able to investigate here is, specifically, does the psychoactive agent portend to a diagnosis of certain psychiatric illnesses? And if so, are those with psychiatric disorders potentially self-treating, or are they patients who are victims of impaired judgment due to their disease, which leads to substance abuse? We would like to thank the Summer Scholars Research Program at the Brody School of Medicine for helping to provide a stipend for Dr. Cora. And our references for this post are listed here. I know that was fast, so I'd like to open it up for questions.
Hello, everybody. My name is Zachary Michaels, and I'm going to take you through this abstract today, COVID-19 and Trends in Suicidality in a Massachusetts-based emergency department system. I have no relevant disclosures, and neither do any of my co-authors at this time. A little bit of background to get us started. So, as you may know, some concerns have been raised regarding the psychological impact and potential for increases in suicidal ideation and suicide attempts in the context of the COVID-19 pandemic. This is due to a variety of reasons, including documented increases in symptoms of depression and anxiety, increases in social isolation. We have evidence to support links between economic hardships and suicide rates in the past, as well as historical precedents from things like the SARS virus and its relationship to impacting suicide attempts and suicide rates in older adults. In the context of all of this, there have been mixed reports of emergency mental health data and suicide ideation and suicide attempt data from emergency departments nationally and internationally during the pandemic. Therefore, the objective of this study was to examine trends in ED visits related to suicide attempts in Massachusetts, or rather a Massachusetts-based ED system during the pandemic, in order to look at these trends in our own community and our own region. Some methods to get us started. Essentially, we looked at 300,000 or roughly 300,000 electronic health records of ED visits to assess for suicide attempt related visits pre and post pandemic as a percentage of total ED visits. We looked at people over the age of 12 with a mean age of 47 and 51.1% female. We ended up using 2018 and 2019 as an aggregate to use as a control when compared to 2020 to account for changes in suicide attempt data or trends that kind of adjust for seasonality. We used ICD-10 diagnostic codes to look for suicide attempts as defined by the National Health Statistic Report in 2018 by Hedegaard et al. Logistic regression models were fit for each measure of suicide attempt and then compared to their matching results in 2018-2019, adjusting for variables such as age and sex. And so when we did all this, essentially we learned two things. If we plot suicide attempt in 2020 compared to 2018-2019 as a percentage of total ED visits, as you can see here in figure 1, we ended up seeing a large, statistically significant increase in this percentage of suicide attempts in March 2020, which is what we used as the pandemic change point. This remained elevated through April in a statistically significant fashion, and then started to decline back down to pre-pandemic levels towards July 2020. So in conclusion, using this ICD-10 diagnostic data, we observed an increase in suicide attempts as a percentage of total ED visits at the beginning of the pandemic in 2020 compared to the aggregate of 2018-2019, and observed a gradual decline back to baseline by the end of July 2020. It's important to note at this point that reported trends in suicidal behavior nationally and internationally have differed among various studies, which is likely due to a few reasons, both geographic variation in the actual studies and to differing methodologies as well, like using raw numbers instead of total percentages to look at ED visits, looking at things like suicide deaths rather than attempts, or looking at something like suicidal ideation and attempt as a whole of suicidal behavior. These are all going to tell us very different stories. Our results, therefore, tell a different story in that we looked at only suicide attempts defined by ICD-10 diagnostic codes. We compared trends to past years to control for seasonality, and we used percentages of total ED visits. At this point, our next steps would be to utilize additional methods of data collection like patient screeners to assess for visits where people appear for suicidality, as well as for people who present for other reasons, and we then identify some sort of suicidality. We would also want to look at suicidal ideation and extend our data collection window to December 2020. Thank you so much, and I'll take any questions at this time.
Hi, my name is Dana Sacco, and I'm an emergency medicine physician at New York Presbyterian, Columbia University Medical Center. The title of this abstract is Increased Number of Emergency Department Visits for Mental Health Complaints During the COVID-19 Pandemic. I have no conflicts of interest, and this work was supported by the National Foundation of Emergency Medicine. So since the beginning of the pandemic, we've been studying how COVID-19 causes physical illness, everything from mild symptoms to the critical illness that causes some people to be placed on ventilators. Less has been studied about the pandemic's psychological impacts. I don't mean the psychiatric sequela of having had COVID, but rather, how does the stress of living through a pandemic affect our mental health? These graphs are taken from the CDC's Morbidity and Mortality Weekly Report showing the incidence of infection in New York City. As you know, COVID affected New York City early and fast. This first graph represents cases, then hospitalizations, and deaths. Hospital workers took care of the patients who were sick, but what about the communities these patients were coming from? What impact did one's friends and families contracting COVID, and in some cases dying from it, what impact did that have on the psychological well-being of others in the community? Put another way, what is the psychological toll of living through this pandemic? There have been many theories about the impact of COVID-19 on depression and anxiety, but few studies have tried to quantify its effect. Some studies have tried to survey the population in regards to self-reported depression and anxiety symptoms. Other surrogate markers, such as increased alcohol consumption and calls to a suicide hotline, point towards increased depression and anxiety at large. Our study aims to take a closer look at the ED visits for psychiatric complaints that were occurring during the height of the COVID-19 pandemic and several weeks after. We included all patients with ICD codes consistent with anxiety, depression, and suicidality during March 15 to July 31st, and compared this to the same time period in 2019. The next 3 slides are graphic depictions of ED visits. This top graph represents overall patient volume in our ED, and you can see that a couple weeks after the pandemic began, in early April, our volume plummets to about half of our typical volume. Yet despite this, what is happening to the rate of ED visits for anxiety? Here in the bottom graph, you can see this top red line is a relative frequency of visits for anxiety in 2020 during the height of the pandemic as compared to the same months during 2019, which is the blue line below. You can see around week 9, these lines diverge and don't converge again until many weeks later, indicating a greater relative frequency of visits for anxiety in 2020 compared to 2019. This next graph shows relative frequency of visits for depression, again with the red line representing the height of COVID in 2020 as compared to the same time period in 2019. With the exception of this one data point at week 11, the lines are pretty divergent, starting around week 6 and all the way through the end, except for week 11. It's clear that the relative frequency of depression is greater in 2020 compared to 2019. And on the other hand, with suicidal ideation, these lines converge kind of all over the place, back and forth, in comparison of the relative frequency of visits for suicidal ideation in 2020 versus 2019. We then calculated odds ratios for each of these psychiatric presentations. The odds of presenting with anxiety were significantly greater during the height of the pandemic than in the previous year, and this association was strongest for patients presenting with depression. On the other hand, presentations for suicidal ideation were not significantly different during the height of the pandemic as compared to the previous year. This study points to the importance of interventions in the acute setting for mental health complaints and also allows us to think about risk stratification for those who may be at greater risk for poor mental health outcomes. The ways in which COVID has impacted patients have been staggering. However, we must also be aware of the psychological burden on society at large, particularly through anxiety and depression. As vaccination rates increase and case numbers decrease, we must remember that the public health impacts are likely further reaching and will require continued outreach to some of our most vulnerable communities.
Hi, I'm Dr. Fu. I'm one of the PGY2s at Staten Island University Hospital, Department of Emergency Medicine. I'll be presenting my project on characteristics of opioid use disorder patients offered medication-assisted treatment in the emergency department. So a bit of background, the opioid epidemic is well known in the United States. It's been ongoing since the 1990s and accounts for close to 50,000 deaths a year just from overdose. Not to mention the costs of healthcare, lost productivity, addiction treatment, and criminal justice involvement. So medication-assisted treatment, or MAT, is currently one of the most effective ways to treat addictions and includes the use of FDA-approved medications like buprenorphine, methadone, and naltrexone, has been increasingly popular with initiation in the ED to treat withdrawal. So this study looks at the demographics and clinical characteristics of opioid use disorder patients presenting to the ED, subsequently evaluated for MAT. So going on to the methods, this study was a retrospective single-center study of 129 adult patients, came to the ED between July 2018 and July 2020. They were evaluated for opioid use disorder and then assessed for MAT treatment. So at this institution, the opioid use disorder patients are identified either in the triage by the chief complaint or by the nurse or ED provider when they're evaluated. They then follow a pathway where they can either be treated for withdrawal by initiation of Suboxone, which is a combination of buprenorphine and naloxone, and then made an outpatient appointment with our addiction services, or if they're not in withdrawal, simply given a referral appointment to the same outpatient clinic. All patients who were assessed this way had their information gathered and entered into our data collection system, which was used for the study. Going on to the results, in total, after evaluation for MAT, based on these hospital guidelines, 50% of them received MAT, 36% received only a referral, and 13% refused treatment of any kind. So these patients had a median age of 36 years, an interquartile range of 28.5 to 45 years. And the majority of them were males at 73%, white at 72%, single at 65%, unemployed at 57%, with no insurance or public insurance 69%, and no primary care follow-up at 51%. Heroin was the most frequently abused opioid at 52%, followed by oxycodone at 18%. Another thing we noticed was that most of these patients who presented had a chief complaint of detoxification or withdrawal, 56%, which is clearly related to opioid use. However, 19% were other common ED complaints like abdominal pain, altered mental status, chest pain, and seizure that could potentially have been missed if not identified by the ED provider, the triage nurse, or the nurse taking care of the patient. Here's the table of our results, the characteristics of patients evaluated for MAT. Obviously, we couldn't include all the figures. And then kind of our conclusion is this is a simple study that looked at the important demographics and clinical characteristics of potential candidates for MAT. And just to recap, these patients are normally white males who are single, unemployed, public or no insurance, no primary care follow-up, and they're clearly more likely to be assessed and treated with MAT. So we hope that this information can help ED providers recognize and target interventions for patients from this vulnerable population. Here are my references and my disclosure. Thank you.
Hi, my name is Hiba Samaha, and I'm a PGY2 emergency medicine resident at St. Mary Mercy Hospital in Livonia, Michigan. And my presentation is titled An Examination of Lab Result Influence on Hospital Admission of Emergency Department Psychiatric Patients. So, going into our background and objectives, we all know that mental illness is highly prevalent in society and in the ED population. Over half of Americans will be diagnosed with a mental disorder at some point in their lives, and approximately 3.4% of patients who present to the ED do so because of psychiatric concerns. Despite the high prevalence of mental illness, however, current guidelines from the American College of Emergency Physicians indicate that routine laboratory screening is not indicated in a psychiatric patient population. Many ER physicians feel that such testing isn't really even beneficial to begin with. Yet, we do know that some patients who present with psychiatric complaints also have comorbid or underlying physical illnesses that require treatment. In these cases, laboratory screening may be useful if it assists with clinical decision-making or disposition. Therefore, the purpose of our study was to look at whether or not laboratory screening or other patient characteristics were associated with hospital admission versus psychiatric admission in patients who present with psychiatric concerns. So, going into our methods, this was a non-experimental, retrospective, descriptive correlational study that reviewed the electronic health records of 467 patients at a community hospital aged greater than 18 years who presented with a primary psychiatric chief complaint. Those chief complaints included suicidal or homicidal ideations, psychosis, and hallucinations. And we looked at exclusion criteria, which was patients being less than 18 years old or did not have a psychiatric chief complaint. And then afterwards, we evaluated the labs that were ordered on these patients and in the disposition. The data set was compiled, cleansed, and analyzed using SBSS version 25 software. Going into our results, patients aged ranged from 18 to 96 years old, and the average age was about 42 years old. The patients were split pretty evenly between sexes, so approximately 248 were male, about 53.1%, and then 219 were female, or almost 47%. And we found that 5 factors were significant in determining whether a patient was admitted to a psychiatric or medical unit. Those were the age tertile group, so patients who were older were more likely to have conditions that would require medical admission versus psychiatric condition. The chief complaint that they came in, and this was looking more at was it a chief complaint relating to chemical withdrawals or behavioral issues. The total number of abnormal labs, and we found that patients who had a higher number of abnormal labs were more likely to be admitted to a medical unit. The abnormal SGPT lab value, those patients, if that was present, they were also admitted to a medical unit, and the abnormal initial sodium value as well. There were three statistically significant predictors of admission to a medical unit, and those were female gender, abnormal SDPT lab value, and abnormal initial sodium value. So going into our conclusions, in our cohort of 467 patients, we found that the majority of patients who had an abnormal SDPT and sodium lab values were actually more likely to be admitted to a medical unit. So this would suggest that routine evaluation with medical screening lab studies does appear to have some sort of effect on the disposition of psychiatric patients in the ED. Thank you.
Welcome to our presentation, ED to Foundry. My name is Dr. Skye Barbick, and I'm calling from the University of British Columbia. I think there are lots of holes in the system, and I don't think we're particularly serving our youth mental health patients very well in the ED. We can do so much better in British Columbia. I'm representing a team of multidisciplinary clinicians, including young people who are meeting together to understand how do we best serve young people in the emergency department? How do we connect them to services afterwards, where and when they need it? I want to acknowledge Michael Smith Foundation for Health Service Research for their funding for this project. We're going to run you through what is ED to Foundry, I'll tell you what we did and tell you what we found, and to talk a little bit about so what. 1 in 4 young people in North America, specifically in British Columbia, experience a mental health condition each year. And since 2008, the rate of emergency department visits has increased for young people with mental health challenges by 85%. So in response, in British Columbia, we've designed an innovative program and service centers for young people called Foundry, where young people aged 12 to 24 can access centers across the province, both in person and virtually, to receive a range of services, including mental health and substance use support. Since 2018, we have served over 25,000 unique youth. And really our understanding in these communities is how do we actually work with our emergency department providers to ensure that young people who are showing up to the emergency department, where and when needed, are actually connected into to Foundry services after an ED visit. So our plan was to actually do focus groups and to co-design a process for assessment, treatment, and connecting young people into Foundry services from the ED. But COVID hit, and so as a result, instead, we did multiple individual stakeholder interviews with youth, families, ED providers, and Foundry providers from across the province of British Columbia. We wanted to understand what the experiences were, both the current and the ideal experience. We also wanted to understand assessment and treatment experiences and how young people were being connected currently and what the ideal situation could be. So what we found were 6 main themes. The first theme was things have to change or one day I will die trying in a system that never let me try. The department was identified as highly stigmatizing and not youth friendly. Theme 2 is it can be way better if you include youth, families, and ED providers working together in the planning. Safe spaces designed for youth, designed for a mental health crisis, were identified as clearly important, but doing those alongside, designing them alongside young people and families and end users is very important. It is reasonably negative and disjointed. The presentation experience for youth is sort of out of desperation and sort of out of being unable to access other resources, accessing a service with a medical model that is primarily designed for quick access and discharge. It doesn't really provide much for engagement or connection. It's really designed to get me out of sight as quickly as possible, said a young participant. Theme 3 is I only have to tell my story once. And theme 4 is we all have the same way of communicating. And this was identified across all stakeholder groups who were interviewed, that all stakeholder groups wanted to have a seamless way of understanding, quickly identifying the needs of young people, and being able to ensure that we all had same goals for care and connection into services. Basically, there's no systematic way of assessing young people, and there are huge barriers and consequences to this. ED physicians have to know about what to ask and where to send people. We actually know very little, and we are starved for this information. I can actually sit and have a cup of tea before I go to the ED. I know I'll be stuck in the hallway. I know he'll be stuck in the hallway in restraints for a long time. I'm gonna have to come in, I'm gonna have to have the energy to navigate the system and advocate for my child and a family member. We also found not another pamphlet. Young people did not want another pamphlet. They wanted to be connected into services that were meaningful and useful for them. If I could have 24 access to somebody coming in to help that bridge the emergency department, that would be great. As our struggle with substance use and mental health presentations, having timely access to that connection at appropriate times would be great, rather than a patient and family consistently needing to seek out resources that basically try and help navigate their system on their own. And finally, we need to work together. I'm incredibly proud of my team. They are special. The system can be ridiculous. It can be shitty. It can be uncaring, all of those things. There are people in the system that actually do care, and there are people in the system who are going to do good work. So basically, the study builds a youth-centered ED experience profile. It raises awareness of how Foundry can support a referral process to services where young people need them. It develops a youth-friendly assessment and care pathway, and it's informing research decisions and policies and system decisions within our province. I end with a quote. I know it can be really exhausting when you see the same people over and over again, but in the ER, I always really hope that people can see the bravery and the courage in that. They're just trying to be themselves, keep themselves alive. And whatever we attempted before didn't work for whatever reason. And I think some people can get weird perspectives about that versus seeing it for what it is. Thank you.
Hello, my name is Sarah Thomas, and I'm a research intern with the Center for Vascular Emergencies at Massachusetts General Hospital. Today, I'll be discussing our group's work on seasonal variation in diagnosis and severity of PEs. PE is a major cause of cardiovascular death in the U.S., and several studies suggest there is seasonal variation to PE. The reported variation in monthly PE diagnosis may be due to pathophysiologic factors or confounding. We sought to address this knowledge gap by analyzing 2 large registries. Our goals were to 1, identify if there are temporal trends in both diagnosis and severity of PE, and 2, describe the nature of those trends. We conducted a retrospective analysis of 2 pre-existing databases from a large urban academic medical center. The first database was an outpatient database containing 1,324 patients with confirmed PE over 36 months. The second database contained 1,082 cases of severe PEs or PE response team activations over 72 months, overlapping with the first database. In our hospital, all severe PEs receive a PERT activation. Using these data, we set our outcomes as PE diagnosis for the outpatient database, and we used PERT activations as a proxies for severe PE. We used one-way ANOVA for 1 calendar month or member of PEs, and 2 calendar month and severe PEs. To avoid executing a large number of post-hoc pairwise comparisons for calendar months of severe PEs, it was instead decided a priori to plot the results for visual inspection. This approach minimized type 1 error risk while enabling preliminary identification of temporal patterns warranting further statistical exploration. We then used Poisson regression to characterize the nature of those relationships given the count nature of the data and relatively low numbers. For the consecutive sample of PE diagnoses, we found ANOVA did not reveal a statistically significant association between calendar month and number of PEs. However, for severe PEs, ANOVA did reveal a statistically significant association between calendar month and severe PEs. After Poisson modeling suggested at least one bend in the curve representing association between calendar month and severe PE, plotting was executed to ascertain the fit of a cubic model. Plots were generated for mean number of severe PEs per calendar month. When considering the output for the Poisson models using the peak month of November for the first model and the nadir month of May for the second model as the baseline months, a cubic fit seemed appropriate. Such a fit was confirmed with plotting of both the fit and its 95% confidence interval, and also with execution of a cubic polynomial model with significance testing of the cubic term. The plot shown demonstrates the similarity between the regression model line, which is a prediction of the number of severe PEs, and the lowest trend line. There are, however, limitations of our approach that should be mentioned, the first of which is that this was a single-center study with a relatively low study number. We also acknowledge the limitation of using PERT activations as a proxy for severe PEs, though our institution has a relatively mature PERT and all severe PEs get a PERT activation. There is reduced likelihood of confounding by number of tests given we looked at severe PEs, which are unlikely to escape attention. It could be that new residents order lots of tests in July, but our peak was months later around November and December, so this seems unlikely. The preliminary indication from these data is that there is seasonal cycling of severe PE. There was not a significant association between PE diagnosis and calendar month. However, there was a significant association with severe PE. Specifically, we observed a nadir in spring that increased to a peak in late fall, early winter. This is in line with findings of previous groups, including Manfredi et al. In Italy, which suggests that there may be additional factors at play besides resident turnover. These observations may be attributable to increased risk factors like sedentary behaviors in the winter, or perhaps inflammation due to seasonal illnesses like influenza. Thus, further studies are indicated to investigate the potential seasonality of severe PEs.
Hi everyone, I'm Nick Russell. I'm a second-year resident at East Carolina University Medical Center. Welcome to my ePoster, which is titled NIH Stroke Scale in Stroke Activations, Initial Emergency Medicine Physician Scores versus Neurologist Scores. The original purpose of this research was to focus on whether or not resources were being utilized appropriately during stroke activations for patients with low NIH stroke scores. And our institution, which is a tertiary care center located in Greenville, North Carolina, we activate strokes for any person who is within the TPA window or the LBO window, which functionally means anyone with a suspected stroke within the 4-hour window or 24 hours of symptom onset. There was some concern that this may be somewhat resource intensive, as our code stroke activation process involves activating a stroke neurologist that shows up to evaluate the patient, typically along with one or more mid-level providers who are also on the stroke team. This stroke team covers the entire hospital, and there are times when this leads to repetitive stroke activations throughout the hospital and the emergency department. One of the questions is whether or not this is necessary, and particularly is it necessary when stroke scores are low. To examine this, we looked at the stroke scores that were performed by emergency physicians and compared them against stroke scores that were performed by the stroke team. The purpose here was to see if there's a difference or if a large portion of the activation is more focused on the decision to give TPA, which at our institution is done under the direction of the stroke neurologist. The way we looked at this was using a single institution retrospective study, looking at all of the activations that occurred over the past few years from 2015 to 2019. And our inclusion criteria were primary activations done at Vidant Medical Center or out in the field, with exclusions for transfers or for canceled stroke activations, which frequently were those cases where an encephalopathic patient was initially considered to be a stroke during the initial triage process. During our analysis, there was some concern that frequently the emergency physician and the stroke neurologist were simultaneously scoring an exam, and to prevent this bias, we took a look specifically at the cases where the scores do not agree and use this as a proxy for independent scoring. When we do this, we see that emergency physicians and stroke neurologists still score very similarly. On average, there was a score of a 10.68 plus or minus 7.49 for emergency physicians and a 10.27 plus or minus 7.52 for stroke neurologists. And the difference, for the absolute difference between individual scores, was usually fairly low, averaged between 1 to 3, though there was some clustering at the lower stroke scores. We also see that these results are not heavily biased in one direction or another, which helps the statistical validity of the study. The initial result, thus, is that there's no significant difference in scoring when done by different medical doctors, and we see this graphically represented in the first and second figures on this poster. A secondary question was whether or not we could predict outcomes based on the stroke scale, which has been suggested in the past and was previously validated during the initial studies that developed the NIH stroke scale. Well, we found that our institution was somewhat surprising, but not necessarily unexpected. And what we find is that while the mid-range scores, those scores between about 4 and 12, are highly significant, we don't find a significant association between the score and stroke for very low scores under 4 or for very high scores over 13. It's somewhat unclear exactly why this has happened. For the low scores, it may be explained by people who just have minor focal weakness, which can happen for a variety of reasons, but it was more surprising for the higher scores and suspected to be due to more global encephalopathy causing inappropriately high scores. So when we look at our data, we can see in figure 3 that when we compare what ultimately turned out to be a stroke versus situations that turned out to not be a stroke, the non-strokes are clustering at the lower end of our score, and this makes sense for why we find that statistically significant area with the higher scores. We did a secondary analysis of this and looked specifically at the scoring between stroke neurologists and emergency physicians compared to outcome, and we see that in cases in figure 4 where the stroke does occur, the stroke neurologist and the emergency physician agree very strongly on the same scores, while there is a more broad difference when a non-stroke ultimately is diagnosed. That's about all the time we have. So thank you very much for coming to our poster. The next work that we'll be doing is doing further analysis of scoring for subgroups to see if there are other underlying health conditions or medications that may predispose people to have inappropriately high scoring, and to look whether or not emergency physicians are sufficiently sensitive on their initial scoring. Thank you very much.
Hello, my name is Paula Govetsky, and I am currently the emergency medicine pharmacy resident at the University of Chicago. I am honored for this opportunity to present my research project, which is titled Pharmacist Involvement with Anti-Epileptic Therapy for Status Epilepticus in the Emergency Department. I would like to start by saying the authors of this project have no conflicts of interest to disclose. Seizures in status epilepticus are commonly encountered in the emergency department, or ED. Studies show variability in choice of anti-epileptic, dosing, and time to administration. There is little information as to how these factors affect clinical outcomes, and lack of data regarding the impact of pharmacist involvement for this patient population in the ED. The purpose of this study was to evaluate differences in anti-epileptic therapy for status epilepticus patients presenting to the University of Chicago ED when a pharmacist was and was not present. This was a retrospective single-center observational study, which included patients over the age of 18 who presented to the University of Chicago ED and met the American Epilepsy Society's definition of status epilepticus. Patients who had a code stroke activation in the same ED encounter were excluded. The reason for this being, there is a pharmacy resident on call 24 hours a day at our institution who responds to all code strokes. Therefore, it would be unknown as to whether the pharmacist was still present or not if and when the patient seized. The primary outcome was time to administration of first anti-epileptic. A total of 20 patients met eligibility criteria, 13 of them being in the pharmacist present group and 7 of them being in the no pharmacist present group. Patients were categorized into each group depending on the time of their ED presentation and whether an ED pharmacist would have been scheduled to be staffing at that time. At our institution, we currently do not have 24-hour pharmacy services in the ED. Baseline characteristics are listed in Table 1 with no significant differences between groups. Figure 1 displays time to anti-epileptic administration. Time to AED1, which was the primary outcome, showed no significant difference between groups, with a median time to administration of 26 minutes in the pharmacist present group versus 37 minutes in the no pharmacist present group. For time to second anti-epileptic, there was a trend towards significance, with a median time to administration of 51 minutes in the pharmacist present group versus 171 minutes in the no pharmacist present group. For time to third line anti-epileptic, there was no significant differences between groups, median time to administration of 205 minutes in the pharmacist present group versus 335 minutes in the no pharmacist present group. Patients in the pharmacist present group had more appropriate doses of first, second, and third line anti-epileptics, although this was not statistically significant. Patients in the pharmacist present group had higher median total lorazepam equivalents administered, 2.5 milligrams versus 2 milligrams. There were no significant differences in rates of hypotension within 60 minutes of first anti-epileptic administration, no difference in intubation rates or 30-day mortality. Patients in the pharmacist present group had significantly shorter median ED lengths of stay and a higher rate of intensive care unit admissions. Limitations include this being a single center study with low enrollment of patients. Therefore, this does not fully capture the variability of prescribing practices and reduces external validity. The investigators also cannot guarantee pharmacist involvement or lack thereof in either group. As previously mentioned, patients were categorized depending on their time of ED presentation and whether an ED pharmacist was staffing at that time. However, the pharmacist may have been occupied with another more critically ill patient or other departmental activities at the time of the patient's arrival. Additionally, patients in the pharmacist present group appeared to be more critically ill. There were more patients in the pharmacist present group that were intubated, despite this not being significant. There was significantly higher rates of ICU admissions in the pharmacist present group, which may have correlated with the shorter ED length of stay. Despite no significant difference in time to first anti-epileptic, pharmacist involvement resulted in overall shorter times to anti-epileptics, a larger dose of total lorazepam equivalents, and shorter ED length of stay. Larger multi-center studies are required to capture a pharmacist's impact on medication management in status epilepticus.
Hi everyone. Today I'll be presenting on my research looking at the impact of emergency medicine pharmacists on treatment of seizures. I have nothing to disclose. Seizures are associated with significant morbidity and mortality. Timely cessation of seizures is the only modifiable prognostic factor in preventing neurologic injury, which can be improved by rapid administration of anti-epileptic therapy, which I'll refer to as AED, at appropriate doses. Emergency medicine pharmacists, which I'll refer to as EMP, have been documented to reduce door-to-balloon time and diagnosis time in myocardial infarction, as well as reduce door-to-TPA time in stroke. Hospitalized patients receiving pharmacist-managed AEDs have been shown to have significantly lower mortality and hospital length of stay, but there's a lack of literature describing pharmacist impact in the emergency setting. Based on this, we hypothesized we would decrease time to AED therapy. This was a single-center retrospective cohort study in the University of Vermont Medical Center Emergency Department. The primary outcome was time to AED administration with or without EMP involvement, validated on the basis of order verification and medication dispense records. Patients with acute seizures requiring IV AEDs, as listed on the poster, were included. Those with anoxic brain injury, hypoglycemia, or hyponatremia were excluded. We also performed a sub-analysis of time to administration for patients presenting in status, as well as time to administration regardless of validated EMP involvement, and instead on the basis of EMP schedule. For secondary outcomes, we assessed rate of appropriate AED dosing in patients with status, rate of seizure recurrence within 48 hours, cost of encounter per day, and mortality. At this time, seizure recurrence and cost data are not available and will not be reported on. Fisher exact and chi-square were used to compare categorical data and t-test to compare continuous data. A multivariate linear regression was used to assess the primary outcome, adjusting for confounders such as medication dispense location, shift, age, weight, whether they received pre-hospital medications, and admission status. We used a natural log transformation to meet the assumption of a normal distribution. There was no significant difference in patient baseline characteristics, and the most commonly administered AED was levetiracetam. The mean time of AED administration with EMP involvement was 44.4 minutes compared to 43.7 minutes in the non-EMP group, which was not statistically significant. Adjusted analysis also demonstrated no difference. Looking at scheduled EMP involvement and EMP involvement for status patients, again, there was no statistically significant difference in time. We also assessed factors which significantly impacted time to administration. These included medication dispense from the automated dispensing cabinet, whether the order was placed during day, evening, or night shift hours, and whether the patient was in status. Referring to the table in the bottom of column 2, patients that received medications from the automated dispensing cabinet during evening shift or presented in status had significantly shorter time to administration. In the figure at the top right, we demonstrate that the rate of AED dosing was more appropriate in patients with status when an EMP was involved at 41% compared to only 5%, which was statistically significant. We defined appropriate dosing based on the American Epilepsy Society 2016 guidelines. Patients receiving lacosamide were excluded from the analysis since there's a lack of quality evidence to define appropriate dosing, and it's not a first-line therapy. Overall, there were several limitations to the study, including its retrospective design, relying on quality and accuracy of documentation, as well as the low acuity of patient population. Both groups had delayed access to AEDs due to sterile compounding requirements, which was a major limitation. Given this factor, along with the low acuity, time to treatment was prolonged even with an EMP on shift to facilitate. The study was not large enough to detect differences in the highest acuity patients, meaning those in status. EMP involvement was not associated with reduced time to administration, but was associated with more appropriate dosing in patients with status. Emergency departments should evaluate their medication procurement process and strongly consider stocking their most utilized AEDs in the emergency department. Future research should aim to assess the impact of EMP involvement in a higher acuity patient population, like for those in status where we know rapid time to treatment is important. I'd like to acknowledge Dr. Porter, Dr. DeWitt, Dr. Sickett, and Dr. Callis for their assistance with this project. Thank you.